Notes about being an adult student.
I know. Sure. Like that. Okay. Hi, guys. Welcome to, wow, there's nobody here. Well, okay, I'll say it for the recording. Welcome to the June meeting of the Human Services Committee of Community Board 2 Manhattan. It's exactly 6:30 and we're 6:31. And so we're going to wait a few minutes until we start. And then we will do everything, introductions and the whole thing. I'm going to mute myself for a little bit. I'm going to wait until 6:35 and then we'll start, no matter where we are. Donna, I'm promoting you to panelist in case you want to attend. You've declined. Okay, that's fine. Yes, Donna, I see your message. That's fine. I think we really actually have to wait until our first guest shows up from the Show Vans program, which actually is an H+H program. But he said he had a commitment at 7, so he was happy to see that he was first on the agenda, but now I don't see him. So let me.
Exercise, and it was
Hi, Andy.
really cold.
I promoted you to panelist.
And everything.
And I don't, if Emma Hutchins is on your team, you'll let me know. Otherwise, welcome, Emma. We're going to start the meeting very soon.
Thank you. Yeah, I'm here, and I'm the only one from my team who will be here. So
yeah, that's my understanding. I don't know why I don't see you.
Panelists, maybe.
Panelists. But there's Andy, but I don't know. Let me see.
Oh, his
gallery. I should see him.
This video is off.
Oh,
You can.
Andy, you can turn your video on if you don't mind. Maybe that will allow us to see you, although I should be seeing your name anyway.
In full transparency, I have I play hockey at 7 p.m. and I am doing this well.
All right,
My
okay,
stage.
so you're all suited up. All right, fine. So we're
I'm
gonna just
sorry.
do it
But
faceless.
I wanted to make sure I was here and.
Yeah,
I'm
okay,
sorry.
guys, you know what, it's 6:36, so we're gonna start.
Okay.
Welcome to everybody who is watching this recording or tuning in. This is the June meeting of the Human Services Committee of Manhattan Community Board 2. We're gonna start with introductions. I'll tell you what our agenda is. We have 2 items on our agenda tonight. The first is we're gonna have a discussion with Andy Cook, who is involved in the show van program, and you'll hear a lot more about that. And the purpose of this conversation is to understand whether the show van is something that we as a community board would like to advocate for our community district. Then we're gonna meet with Irfan Karim from Health and Hospitals, Bellevue Hospital. We have a lot of questions about the impact of the MSBI closure, the Beth Israel, Mount Sinai Beth Israel closure. So let's get to it. We'll start with introductions. We don't have a forum tonight. Okay, we have an informational, this is an informational meeting. I'm Susanna Aaron. I'm the chair of this committee.
And Anna Scott, member of the committee. Rachel Yarmolinsky, public member.
Janet Liff, full board member and member of the committee.
Great, and we know, Andy, that you have a very important professional engagement at 7 o'clock, so we're not gonna waste your time.
Sorry, I'm not a pro, but yes,
You're what?
not a professional, not by any means.
Oh, I know, I was joking.
I know,
I was
I know.
In your dreams, it's a professional.
Yeah.
All right, so can you just tell us about the show van program? Tell us where it comes out of, tell us what the acronym means, tell us how it works.
Totally.
And tell us where you're located. And this is gonna be an open discussion with anyone in the room. It's a very small group. So go ahead.
Perfect. So yeah, I'm Andy Cook, the administrative director for the show, which stands for Street Health Outreach and Wellness Program at New York City Health and Hospitals. The way we can think of it is street medicine. So street medicine being primary care along with other services that is brought to the street to try to help and engage people who are street homeless or otherwise experiencing unsheltered homelessness and try to meet medical, material, and ideally work with them towards meeting housing needs as well. We currently have 5 show units across the city. Each show unit is affiliated with one of our Health and Hospitals facilities, and specifically with facilities that have what we call a safety net, primary care safety net clinic. And that's just an important connection because the primary care safety net clinic is a primary care clinic at a facility that is really designed to meet the complex needs of people who are both experiencing homelessness and who have chronic medical conditions. So the facility.
Yeah, what facility is the closest to us and what?
So
yeah.
The closest one would be Bellevue, with the other facilities being Elmhurst in Queens, Lincoln in the Bronx, and Woodhull in Brooklyn. Bellevue operates 2 show units, one of which is located at Sarah D. Roosevelt Park. The other one is uptown in the like East Harlem area.
Got it.
Yeah.
You know what, can you just tell me, Health and Hospitals, is that an arm of the city?
Kind of. We're a public benefit corporation, so we're like a quasi city agency. So like our CEO reports to a board as opposed to the mayor.
Okay.
But yeah.
We don't have to go into that too much, but so
Sure.
tell me, first of all, can anyone go up to these vans? They're stationary, right?
Yes, yeah, they're stationary, and that's by design because we want our patients most of whom, do not have access to cell phones or the internet, etc. We want them to know, where we are and to be able to reach us and consistently engage with us. Of course, anybody could go up to one of the teams. And speaking of the team, it generally includes a medical provider, nursing staff, social worker, addiction counselor, community health worker, and a clerk. And that team will spend some of their time at the van. We call it a van. It's more of like an accessorized size minibus that can function as a clinic. They'll spend some of their day at the unit, and then other portions of the day they'll do what we call roving. So they'll walk around basically and canvass the area anywhere from like a half mile to a mile, or sometimes even farther by using transit, to engage with either known patients or potential patients, and distribute harm reduction supplies, do wound care or other kind of basic primary care, and just otherwise try to engage with folks who may be on the street.
So the staffing of each van, each one of these little accessorized vans, as you described them, has how many people, how much staff on it at any given time?
Yeah, when we are fully staffed, we would have about seven staff members, including medical staff, social worker, and addiction counselor, community health worker, and support staff.
And when you say when you're fully staffed, what percentage of the time are you fully staffed?
Right now, both of our Bellevue units are fully staffed, which is great. But it's difficult work and demanding and requires kind of special people. So sometimes not all of our units are in the same state.
So when you say that, so when you're not fully staffed, it's not because you have different shifts for people, it's that you just can't
That's right.
fulfill the staff.
That's right. Yes.
And what are the hours of the van? What are they, 24/7?
It's kind of standard ambulatory care clinic hours, basically. So Monday through Friday, 9 to 5.
9 to 5, got it. And people can just walk in, they don't need an ID, they don't need
Exactly, yeah.
any form of medical insurance and anything. So is one of the aim, first of all, another just sort of logistical question. What is the cost of the vans?
Yeah, so one show unit kind of all in with all, staff, like infrastructure costs in terms of like supplies, the vehicle itself, is about $1.5 million per year per show van to like fully operate with everything that's a part of it.
And the advantage of having them is that you can build them and shrink them presumably as need arises, right? I mean, create one or phase one out, I would imagine, as opposed to building
so
up.
it's unfortunately not that easy. We're funded by the city and we're funded to run 6 units. And so that's kind of the mandate that we have with the funding that we have. So we're almost there with launching our 6th show unit, which will be a 2nd unit out of Lincoln Hospital.
Got it.
Yeah.
Yeah, go ahead, Jen. Exactly.
I'm just curious, how long have you been in operation? Is this just a pilot program? Because it seems as if you wouldn't be having that much coverage with only 5 or 6 vans for the entire city. And do you know how many people you service?
Yeah, so it's baselined into it, like we have ongoing city funds to do these 5 units, or it will be 6 units. In the last 2 years, which is the amount of time we've had the health and hospitals staffed units, we have we've completed just over 30,000 street engagements including about 3,000 medical or behavioral health encounters. So the difference being like an engagement could be handing out harm reduction supplies or, something of that sort, where like a medical or behavioral health encounter would be like the actual delivery of services, of like care, clinical care.
Well, it
And
sounds like an engagement is just, an engagement could be for the client, for the patient, it could be a passive engagement, right? They're just sitting there and you hand them something. Whereas an actual medical behavioral health would be a conversation presumably and an actual exam or something?
yeah, like an exam is a way of thinking about, like, our threshold is kind of like, if it's a level of service where we're documenting it in the medical record, then it's then it would be an encounter. But if it's not something that we would consider like clinical care, then it's just an engagement.
An engagement. And is that sort of like your target number? I mean, do you think you're hitting your metrics in terms of who you'd like to be, how many people you'd like to be serving?
Yeah, I mean, if we think about like the street homeless population in New York City, which, I mean, like the Hope count, which, I mean,
Right.
it's a point in time survey. I think that's around like 4,500 to 5,000. And at any given time, we've got about 1,100 active patients. So it's pretty good considering the population and kind of the number of teams and the footprint that we have. But of course, we know it's I mean, the issue of street homelessness and the associated medical, healthcare, behavioral health, social needs is just, it's massive. But we're trying to make as big of an impact in it as we can.
Do you have a goal to sort of ramp it up? Do you want to have 12 of these out in the next couple of years? Is there?
We're funded for 6 units, so that's what we're working towards, and try to generate as much impact with those 6 as we can.
So I'm gathering that what you're saying is that you were not, when you were funded, there was not a benchmark that you were asked to meet. It wasn't like we want to see X number of patients. There, right? There's just like go out and do your thing and let's see how many patients come, or were you given an expectation or a benchmark that you were asked to hit?
We don't have a benchmark necessarily in terms of the number of patients to like engage or any of that kind of a thing. Health and hospital, yeah, like Health and Hospitals has goals, specific goals around improvement in chronic disease outcomes for patients experiencing homelessness and to assist patients in getting housing, and we're a part of trying to drive those goals. But that's kind of what we're working with. Yeah.
Sorry, I'm just going to keep firing questions. It's a small group. You guys raise your hands and jump in. Rachel, go ahead.
I'm just curious, I'm assuming that it's easier for some people to come to a van than to go to the hospital. Is this truly a different population? Would you like to move some of these people to actually start visiting the clinic? Or is that not part of the goal?
Great question. It is totally a part of the goal. So there are absolutely some patients and some people who we engage with who are or who we see regularly, who maybe because of experiences in the past or whatever it may be, they're never going into a hospital.
Yeah, I told you.
That's fine. We'll provide care where they are or from the show unit. And then there are other people who they're willing to come in, and we open the door basically from that engagement at the show unit, and they are they end up coming into safety net clinic or other specialty care as we refer them to.
Thank you.
Another question I have is whether you think that any of these services have any impact on a patient's decision to come indoors or to seek further services, and that might lead to more stability and better shelter, better outcomes overall. Do you see it as a pipeline?
Yeah, so we do. I mean, we have some success stories of patients, moving all the way from the street into permanent housing. We also, we have patients who maintain better continuity with care. We see, for example, like street homeless patients who are engaged with SHO have a notably higher rate of continuing with primary care. It's about 24% of street homeless patients engaged with SHO, compared to about 9% of street homeless patients this is within the H&H system not engaged with SHO. So definitely seeing impact there as well.
Wait, I'm sorry, can you just repeat that stat? I'm not sure if I understood. So 20%.
So if we think about the universe of people who are homeless, who have been seen in the H&H system, if we break out the people who have engaged with SHO, 24% of them have engaged with primary care in the system, whereas the people who have not engaged with SHO, only 9% have engaged with primary care.
And the people who have not engaged with SHO are people who have come to the hospital?
That's right. Yeah. So they've been engaged in the system in emergency room, inpatient, some other setting. Yep.
Right.
So this is also effectively a cost saving program for the hospital, right? Because those hospitalizations should be less dire for that population who is engaged with primary care.
That's the goal for sure. I don't have any data handy to like demonstrate that to you, but that's definitely, part of the whole aim.
Right.
Yeah, to reduce the number of ER visits by increasing the number of regular primary care. By the way, this is introduce yourself.
Sorry, I'm Zach Kazaz, also on the committee. Sorry, I was a few minutes late.
Wait, we've talked about,
Can I build on the question?
yeah, please go ahead.
And if you've already talked about this, just let me know and I'll get the notes from others. But how does the referral process work for other city services? Like, do you have social workers on hand? You mentioned you had success stories, but if you've already covered
Well,
that.
he did mention that on their staff, you have case managers and social workers, but you might be able to elaborate on that. So someone comes, they have a headache. I don't know.
Sure.
Take us through a patient.
It depends on what the situation is. The team will assess if it's services that we can meet. We'll do that. If it's housing, let's say someone needs their benefits, restarted, we'll connect them to HRA, or we can look up and see if someone is already engaged with one of the other street outreach teams, and we can facilitate some coordination there. Just depends on that patient and their needs, and our team will work through the contacts and connections that they have.
Do you provide warm referrals, or do you have case managers or social workers on staff to help guide them to whatever those additional services that they may be eligible or may already be, connected to in some form?
We do have a social worker on the team, and so they will, they'll work through the systems and connections that they need to connect people to services.
I have a question about, first of all, you mentioned that there are some people who have actually ended up in housing and that sort of thing. I'm going to guess that is a very small percentage of everyone who's coming to the SHO van. Is that fair?
I'm sorry, could I get the question one more time?
Sorry. We just hear so often about how intractable these problems are. So when you mentioned earlier that they have some success cases of people who have started at the SHO vans and ended up in, housing, I'm going to guess that those are sporadic. Those are small.
It's definitely a small number, but I don't have the data in front of me, but we've been at it for 2 years now, and certainly intend to make more inroads there. But especially for a lot of these folks who've been on the street for 3, 5, 10 years, it takes a long time just to build trust back up and then work towards some of those goals.
I also wanted to ask about neighborhood spillover, because should we want to advocate for this to come to our neighborhood, which doesn't necessarily mean we would get one, but I know that residents would be concerned about neighborhood spillover. Are there generally lines outside the van? Do they tend to be a place that draws people from around the area?
I would say they're busy, but not, nothing that would like, I would say probably like disrupt a neighborhood or anything like that. And we're generally in places that our population already is, so
Right.
I would say we're not drawing,
Right.
anything that isn't already there.
Do you handle I just want to make sure I understand. Is it mostly people are coming to the show vans and asking for services of some kind, or is there also proactive outreach?
You said, Andy, that the staff will spend, so in an ideal world, if you have full staff, which is what your goal is, you have 7 people on the van and they spend a certain portion of their time in the van, and then I presume staggered, they spend a certain portion of their time roaming the streets and trying to do outreach and luring people to the van or handing out supplies and that sort of thing. Is that?
That's exactly right. Yep. So we have some, we have people who come to us and then we go find people as well.
Just to follow up on that, do you handle, patients who are experiencing psych episodes? Or is it mostly just medical challenges?
I mean, we of course work with people who are experiencing mental illness. But if it's something that's like a crisis, we would activate EMS. Yeah.
You would activate what?
EMS. We would call 911.
EMS. Okay.
I have another question, which is, I know that the city has a list of like 50 people who are the top most dire cases. And I know that the Village Interagency Task Force, which has recently been assigned to our district, has a list of people of like 15 people that they actually talk about as individuals. These are known faces. I wonder if the same is true for your show vans. You're interacting with a large population, but do you have certain regulars or certain people? Do you come to, have a sense of the people who are your community?
Yeah, I mean, we definitely have our regular patients that we know.
Sorry, I think.
Are you there?
I'm here. Yeah, we have our regular patients that we know and that we find. And all of this is tracked in our medical record. So we're able to maintain continuity just like if people were coming into the hospital.
And do you guys interact with any other agencies? For example, the Mayor's Office of Mental Health, or, is there a line of communication between H+H in this field and any other city agency that is looking to help this population?
Yeah, we have regular touch points with DHS. And then like one of my colleagues who works in the Office of Behavioral Health is actually formerly worked at the Mayor's Office for Mental Health and is in regular touch with them as well.
Got it. Who's that, by the way?
Jason Hansman.
Jason Hansman. Okay, great. Well, I don't have other questions. Does anybody else?
I just had one.
Yeah, please,
one
go
small
ahead. We have, before he plays the hockey. Sorry.
If someone, do you screen for homelessness when you're doing patient intake? Or if someone was just uninsured, very low income, and they showed up to the van, would they be able to get services?
Yeah, I mean, we're not going to turn anyone away. And, we'll figure out people's housing status kind of as they go, but we're not going to turn anybody away, and we'll help people navigate to the resources that they need. If it's not us, and that's just kind of what we do as H+H.
And what are the most common ailments that people come to you with? Is it a headache, or is it wounds on their feet?
I would say a lot of wound care, and then a lot of chronic disease that has gone unmanaged for a long time: diabetes, hypertension, heart disease, and a lot of patients have psych conditions as well.
Psych. Got it. Janet?
Yeah. Do you have medication in the van, so if people need their meds, you can actually help them get them on the spot, or you?
We are able to prescribe, and that our primary care providers can prescribe, and then we have limited over-the-counter medications.
Over the counter, got it, okay. Well, I know you have a 7 o'clock commitment and it's 7:01. I want to thank you for coming. This is really, really interesting. Of course, we would love to have this in our neighborhood. I get everything you're saying about the budget, but thanks a lot for sharing this information.
Yeah, thank you.
Thank you for having me and kind of bearing with me here, and
Yeah.
we'll, as you have any other questions, just let us know.
Okay, terrific. Thank you so
Thank
much.
you. Yep, bye.
Okay, let's go right into our next topic. So do you want to introduce yourself and put the microphone near you?
So, Irfan Kareem, the Chief Clinical Operations Officer in New York City Health and Hospitals Bellevue, which is a level 1 trauma center, the only level 1 trauma center below 68th Street in Manhattan.
Level 1 or level 2?
Level 1.
What's the difference between level 1 and level 2?
The complexity of cases, the trauma.
Gunshot wounds?
Yeah, everything. We do everything.
Right, you do everything, but a level 2 does not do gunshot.
Some of them they cannot, yes.
Some of them
Traumas.
And a level 2 can do psych?
They're different. Trauma is different from psychiatric care. We are, in some ways, we have been known in the community and in media, television, everywhere else as a psych hospital, because we're one of the oldest psych institutions that's there, and we're one of the largest bedded ones. So that's part of what we do as well.
Right, no, I'm asking because one of the main reasons that we want to talk, that I was hoping you would join us tonight, is really to understand the landscape at post the closure of Mount Sinai Beth Israel. So some of these questions I'm asking, for example, I know that Beth Israel had a comprehensive CPEP, what is CPEP?
Psychiatric emergency.
Psychiatric emergency something or other. And Beth Israel had that, Bellevue has that. But no other local hospital. NYU does not have that, obviously. Northwell Greenwich Village Hospital doesn't have that. The Rivington Behavioral Center that Mount Sinai has opened up does not have that. So one question I have for you is, are you seeing an increase in patient load in psych emergencies?
So I think I'll start by talking about Bellevue in general, and then I'll get to the
that's
question.
fine.
I think Bellevue has been around for 289 years. We're the oldest institution. I mean, we predate America's founding in by 40-something years. So we've always been there for the community, and we'll always be there for the community. And that includes, we started with smaller things, the flu, the Spanish flu, TB, and different epidemics, right? We treated the only Ebola patient ever in the US and in New York, and he walked out of our building getting tremendous care, Dr. Craig Stevens as well. And then more recently, HIV/AIDS as well as COVID. Psychiatric care is another thing that we provide. We have 200 plus beds, psych beds that's there. We have a forensic unit with 40 units actually with 100 plus beds there. We also have a child and adolescent inpatient unit that's 60 beds, right? And we're one of the largest institutions treating psych in the city. Almost 50% of all treatments that happen in New York City happens at Bellevue.
Of all kinds?
Of psych, yeah.
Of psych.
Psych overall. And that includes 2 CPEPs. One is child and adolescent, and one is adult. So we have both of those.
Can you
Now,
just tell me once again what the acronym stands for, just for the sake of the transcript?
I don't want
I
to
think
get it
it's
wrong now. It's a
comprehensive psychiatric emergency program.
yes, that is correct.
Wow.
You caught me off guard there.
Okay, never mind.
Yeah, emergency program.
Got it. Okay. So you guys do 50% of all the CPEP work in the city?
All psych work. So it's behavioral health psych related work. we do like 50% of it in health and hospitals, and the majority of it is Bellevue.
And you just described 200 psych beds, 100 forensic beds, 60 child and adolescents. How many other beds? Like what percentage?
We have 900 plus beds at Bellevue.
900 plus.
We're busy.
Wow.
Yeah.
Including these.
Yes.
Got it. So about 1/3 of it is psych work
Yes.
and the rest is everything else.
Other things. So in terms of Mount Sinai Beth Israel closure, I think again Bellevue has been here for a long time and will continue to serve our population wherever
Right.
they come from, and we'll be there and ready for it.
Right.
I think as a public health institution, public hospital, we always have needs, right? We might not have the latest and greatest equipment and facility, but we have the people, we have the staff. You might not know that we are affiliated with NYU, so the providers that are seen in Tisch, they're the same providers at Bellevue, and so they go back and forth using that affiliation. And the residents trained at both places, right?
Oh, that.
So from the care perspective, we offer top-notch care,
Yeah.
bar none. In terms of when we first came in, we did have a census issue. We were busy. We were really busy, and that's we don't want to be busy in the sense that we don't want people to get sick, but
Right.
the fact of the matter is, like, people were
Get
coming
sick.
to us, right? People get sick and they come to us. Prior to COVID, we were probably around 400, 450 patients full in our beds. Now we are approaching 850 to 900 patients, right? So
Wow.
we're
So
quite.
we were like at almost 50% vacancy and now you're.
Yeah, I think
no
it,
vacancy.
well, we built additional units to
Right.
address the new needs. And so we continue to grow as much as we can, but we're landlocked.
So that shrinking vacancy rate is post-COVID or post-MSBI closure?
So it's post-COVID, that's when the trend started. And once Mount Sinai Beth Israel, the word is out there is they're going to close, we started working on it. We're trying to figure out, okay, what's the best way to address it? What do we need? How do we address the needs of the community and meet the needs, right? So once Mount Sinai Beth Israel closed, it was somewhat fortunate timing. I mean, our preparation, we started significant work in trying to become lean oriented. So we created a lean team, think about our flows and how do we find additional beds by making us more efficient, right? So
A lean team is just is not a
It's
term of art.
terminology.
You're just saying that you've worked to streamline your
Yes.
operations.
streamline operations, find ways to capture more patients, get patients out the door that can be sent home, making sure, our flow is correct. We're doing all these things, our bed blockage and things like that, facilities. We optimized all of that over the last several months, which helped. Initially, when Mount Sinai Beth Israel closed, we're fortunate in that the FDNY algorithm slightly shifted, which resulted in a decreased volume for a week or so until it corrected itself. So it gave us a little bit of breathing room to kind of work out the kinks. But since then, that has returned. We are seeing higher volumes. Our EDs does have more patients coming in, including patients that walk in. Also, it's led to higher acuity. Some patients that are coming in
Oh,
are
higher
sicker.
acuity.
So because they're sicker, so they're admitted. So we are dealing with that, right? So that's a result of it.
I want to know if we can just make a distinction between your emergency services and scheduled. Now, maybe that's not the right distinction to make. I'm
So-
very worried about the emergency
So
services.
I am speaking about the emergency.
Okay.
So the emergency room is usually the entry point
Right.
to all the inpatient work. So patient come to our EDs and then they're taken upstairs, right? And that's the vast majority of the patients that are in the inpatient beds. So patients are coming in, they're either walking into the ED or they're taken by ambulance, and that has increased. That has increased over the last several years, and we have seen continue either steadied or increased since Mount Sinai Beth Israel has closed.
You put a number on that capacity, what percentage capacity you're at?
So I don't, from an
110?
ED perspective,
Yeah.
we treat everyone that comes in the door, right?
Right, of course.
And
But
how do we do
measure?
that?
Yeah,
So I think the differentiation is like, how do you meet that demand? Do you hire more staff, which we have done? Do you have a longer wait time? Sometimes that's how the demand is, because in terms of patients that are coming for emergency care, they need to get care, right? So you can't just say no and, hey, we're closed or we're busy. We take care of them, it might be a longer wait. we have met that demand and we continue to meet that demand, right? There are ways where we could advocate for additional resources that will help us to better meet that demand and continue to meet upcoming demand that comes in. This is the summer months where the volume is typically less in the ED. You know, respiratory season and other things in the winter months, you see an increase in volume. So we're cognizant of that we have to continue to improve in order for that volume that comes in that we'll be able to meet and we'll be able to do everything we can. Our psych volume has gone up.
Your psych what?
Volume has gone up. It has, we are at times at capacity. So at those times, what we do for, at least for ambulances, is something called diversion, right? So we
Right.
won't be able to take additional patient because we don't have the room. Ambulance will go to the next hospital wherever that is available. So that has happened from time to time, and that does happen.
Where is that, the next hospital with psych beds?
So it might not, so when they're coming to the ED, it's not necessarily beds itself, but it's the initial assessment in the ED. That could be NYU, that could be the other hospital, Sinai and others, right? So they will skip us and go to that location.
I also heard that when you guys take patients in, psych patients in, and you go beyond capacity, that you divert some of them to Rivington, to the
So-
Mount Sinai facility on Rivington.
So I think that's from the, so as part of, we work with Mount Sinai and, you know, we try to make sure that we're still serving the needs. We did have an agreement, and part of that agreement was for inpatient beds, we're able to transfer some of those patients, but that's not from the CPAP. That's once the patient's upstairs, we were able to send some of those patients over, particularly if the patient was already in the Mount Sinai system. They have been getting care at, whether it's Beth Israel or other Sinai location, we work with them to transfer those patients to those beds. So we have additional capacity at Bellevue to take on additional patients, right? One thing that's unique about Bellevue is we take every patient that comes to the door, irrespective of the ability to pay, right?
Right.
Care for New Yorkers, no exceptions, and
Well,
that's our mission.
That's true of every emergency room, isn't it?
It is through every emergency room, but I think there's different bills that are sent out. For us, the ability to pay is not a determining factor, whether
When they
it's
go upstairs.
during or after, and we take care of everyone, right?
Right.
The Chauvin was an example of that. Like, you know, we try to figure out how do we take care of the New York City population, irrespective of their ability to pay. 70% of our,
Hospital.
we're a safety net hospital.
Definition by the state, is that correct?
Yes.
And that provides you with additional funding? Is that right?
It provides some disproportionate hospital fund funding, which I think I'll make a secondary point where I think the community board and others could advocate for, and we could use help in, is we're highly reliant on Medicaid funding.
Medicaid.
Medicaid funding is 70% of our dollars that come in. Dish funds is also another disproportionate hospital share
Dish
fund.
funds?
Dish funds, that's the safety net funds, that's there for
I've never heard of
uncompensated
those.
care and things like that. And as you know, as they call it, the big beautiful bill that they have
Yes.
passed, I think it's very scary for myself as a hospital leader. That bill itself will cut Medicaid funding significantly, and that will have immense impact. It happens in multiple ways. First and foremost is the care that's uncovered. Patients don't get the care, so they do end up in the ED more often because they're not getting primary care and other longitudinal care. And as they end up in the ED, that costs more. Typically, it is more expensive, but that most means they delay their care, so it progresses further, right? So that has a huge impact in itself. It's also patients that are giving birth, after birth, right? It's the kids, it's the children, it's the maternal health that's impacted. Those things will have a huge impact for us, and it will be difficult for us, because we rely, 70% of our patients rely on it. I think the second part of it is the economic impact, right? We employ almost 10,000 individuals, right? That relies on that funding because we cover our funds or our care through the receipts, right?
Right.
We get it. So that will be impacted as well. The economic activity of the neighborhoods, and all of that is impacted. The last thing I'll say up
30%
front.
of your revenue comes from Medicaid. That means that 30% comes from private insurance companies?
Some private insurance, some of the disproportionate funds and things of that nature.
And are there also additional grants that come from, I don't have any idea about hospitals.
We do get some grants, but they're for earmarked for programs of that nature, typically not direct clinical care.
Got it.
And then
But-
is there other direct money from the state or city?
Or federal government.
There's usually those are grants.
Got it.
There's the
Okay.
pediatric funds. and
Okay,
things like
okay. So like for homeless out, or like a homeless
Yeah, that's part of
medicine or
the-
a specific psych programming.
Research or
Yes.
something like
Got
that.
it.
So
Understood.
there's funds from the city, OMB funds,
Okay.
elected officials, give us funds. Those are like grant-like funds that we apply for,
Okay.
and we advocate for.
Yeah, but the general economics is someone comes in, they either have an insurance card from
Yeah.
health insurance, or they have no money at all, in which case you're getting money from Medicaid to pay for the.
So if they have Medicaid is
They
insurance,
have it.
right? If they have no money at all, we'll try to enroll them, those that are available to insurance, including Medicaid or
Got it.
such a plan, all of those things at the exchange. Or if they're uninsured, we still provide the care. It's a fee scale model where, if you can't afford it, you pay zero. But if you have, some income, then you could pay a smaller percentage of it.
How much does the city or state subsidize you then? You say bring grants in?
I think there's various components to it. I think there's facility enrichment that the city or the state will give us grants for. And those are always appreciated, right? One of the things where
Capital improvements.
capital
basically.
improvement. So one of the things we want and we're advocating for
Yeah.
is upgrades to our CTs and upgrades,
CT?
CT scan.
CT scanner,
Oh, CAT scanner.
CAT scanner. Also, upgrades to something we call a single plane for stroke, right?
A single tank?
A single plane, it's equipment, but essentially it is, we have stroke care, right? Essentially, if somebody suffers a stroke, we're able to treat that patient within minutes and they can walk out of our doors with limited impact. Timing is everything, right? These machines allow, think of a highly trained physician, but I'm going to describe it as a plumber. They're really going in there and unclogging it, right? And taking it out within minutes, right? And timing is everything. The CT scanner will help us diagnose it.
Right.
And then subsequent to that, they could go into the single plane room, the biplane room, and they get the treatment itself. We currently have one CT scanner downstairs. We're adding a second one. We would like to upgrade the equipment. Typically, the life cycle of these are 7 to 10 years. Some of ours are 14 to 20 years old already, right?
Got it.
So we have old equipment. And we would like to upgrade those. We would like a new PICU, right? That's another request. That's $18 million.
Pediatric intensive care unit.
ICU. That is something, we treat patients from all over the city. And from other health and hospitals, they send it to us for specialty care, including the PICU. And we have a really old PICU, right? And would love for you to visit and check out the facility as well. But that's something we are advocating for as well, right? And then there's many other smaller projects, whether it's equipment or capital needs that we always advocate for.
So here's a question, your phone's ringing. A question I have about emergency departments and absorption capacity, right? So one of the closure plan for MSPI required them to talk to their neighbors and show that there was absorption capacity by nearby
Yeah.
facilities. So I wonder how that is defined. We talked to Northwell Greenwich Village Hospital, and the only way they could define it is that when they are at capacity and they have to divert, that's when they no longer have it. Until then, they have absorption capacity. Now, I've been to an emergency room with a kidney stone where I got treated in 20 minutes. And I've been to an emergency room and a kidney stone where it took so long for me to see a doctor that the renal colic was over. What is an acceptable wait time?
It's a very.
Any time is an acceptable wait time?
It depends on what you're coming with, a gunshot versus a
That's what
gunshot.
people always say, but the truth is that if you're short-staffed, obviously you're gonna race to save the guy with the gunshot wound and the stroke. But there's a million other reasons people come to the emergency room. And are they gonna everyone expects to wait a couple of hours in an emergency room, but we know that, in third world countries, I'm gonna guess you can wait 8 hours, right? So is there a limit at what's acceptable?
I'll answer this question two ways, right? I'll bring my personal life story to it, my
Yeah.
previous work and current work to it, and say, how do we kind of think about this and how do we address it? And I'll refer to Bellevue as well and talk about how we're thinking about it. So personal story, first generation immigrant, grew up in Queens, Sunnyside, Queens, and I went to Elmhurst to get my care, right? That's
Wait, immigrant from where?
Bangladesh.
From where?
Bangladesh.
Bangladesh, okay, sorry, go ahead.
So H+H has always been there for us, and it helped us get the care we needed. And where did I go? I went to the ED. Why did I go to the ED? My parents had multiple jobs. They couldn't afford to go to primary care. They had to take days off. That wasn't going to happen. So we made it we go in the middle of the night, and we know it's going to be an 8-hour wait at the time. This is in the early 90s, but that was okay. We went as a family. We got definitive care, right?
Wow.
Which meant you got your testing done, you got everything done, you knew what was going to happen. We're substituting primary care for
An ED for some.
for ED, right? Which is many of our patients do, and there's various reasons for it.
They will wait a
and-
long time.
What was that?
People who come
People
for
wait,
primary
they
care,
understand.
they have a
Yes,
cold,
They understand.
are gonna wait a long time.
Now, so that can be at times throughout the system, 30 to 40% of our volume. That it's the patients that don't need to be there. Over the last several years, so this is where the Morphin story, we created virtual care, right? I used to lead the Virtual Express Care program, which is virtual urgent care, right? So it's 24/7. You can talk to an ED doctor within 5 minutes, right? They can prescribe, they can do different things. Actually worked with Andy in the show vans. We incorporated psychiatric care to that. There's various services available. So that's one strategy to think about how do we leverage our ED to the optimal need
Right.
for the emergencies or the pain from the kidney stones and things like that, versus the lower acuity, the cough and the cold, the COVID
Yes.
that could be treated from home, who don't need to wait
Right,
and do
Right.
these things. So that's one way to address it.
Also, what about all these urgent care centers? I have 2 or 3 on 8th Street within a 5-minute walk of me. Have they had an impact on the demand of the emergency rooms?
I
Assuming that they have slack.
yes and no. I think it's a
I think it's a
complicated
different
thing.
population.
Sometimes it ends up being a different population. It also ends up there's so much unmet need that they have absorbed some of those needs. They do help. So I help run our urgent cares. And so it became part of the solution.
but they don't accept.
the need is
Medicaid.
growing.
They don't do
Well, so
it.
ours did, right?
Yours accepted
Yes.
Medicaid.
They don't even accept all major insurances.
Yeah, that's the challenge.
And MSBI is opening an urgent care facility as, in the wake of its closure, MSBI has opened an urgent care facility, which for 3 months will be open or is it 3 months or 2 years? I can't remember. For a limited period of time, it's gonna be open 24/7 and it will accept Medicaid. After that, we have no idea if it's gonna be.
But I think that's where Health and Hospital has been a fierce advocate of taking care of patients, even uninsured. When I said equity, we meant equity, right? Anyone that comes through the door, they got care, right? And that's true about our virtual care as well. And then it will be my job to figure out how do we get it to pay? How do we make sure Medicaid's still there? We advocate for it, things like that. I think at Bellevue, coming back to us, yes, we've seen larger volumes. We are doing construction and work. We have phase planning on how do we get more ambulances to come in? How do we improve our fast track, which is where lower acuity patients usually go? How do we make it more efficient? How do we get more rooms? How do we get the equipment that we need and rebuild it to the footprint that is required of today, right? Most emergency departments were built, 30, 40, 50 years ago. They were built for those times, right? Emergency medicine is relatively a new field as well. So it might not be adequate to the flows of today. So we're addressing it by dealing with that. What's the adequate wait time?
What do you look at? I mean, obviously you're gonna look at fatality. If people are dying in your emergency room, obviously that's a 5-alarm fire. But do you look at the time it takes?
Yeah.
And how do you, what are considered acceptable times? How does that get looked at?
I think it varies by the need. I think one of the things we look at are left without being seen numbers, right?
Or what?
So left without being seen. So you leave the
Out of
place without
frustration.
even, out of frustration,
Whatever.
or it could be many factors, right? At Bellevue, actually, we've been very good. It's very low. It's less than 1% of the patients, which is really good, even nationally. So that's one metric. We look at our door-to-doc time. So you come in, so like, looking at when you see a provider, right?
Right.
When does a provider actually see you? The total cycle time. There's many metrics like that we're following and we look at. And you want to be in the right level, right? Not every patient is going to be seen right away because again, the gunshot wounds and the traumas are going to take priority. And then you go, and then you build. Physical plan is important. You build. Equipment is important, right? A patient could come in and they might need that CT or an MRI. And if you have one machine, somebody with a lower acuity, 3 strokes come in and something else comes in, they're going to go first compared to that person that has something lower. And so those things are important. So you get multiple machines, you get the staffing for it, and you kind of build it out.
Can I?
Yeah, please, go ahead.
Sorry, I'm taking a few steps back here. But I think a lot of my concern and what our lovely chairwoman has talked about related to the Beth Israel closing is basically time to the hospital, right? Like we've the radius of access to a
Area,
what?
but we're not like, I'm sorry.
Level 1 trauma center just is much further, and like even New York in traffic, like to get from Meatpacking to Bellevue during rush hour, like these things actually can take a fair amount of time. So I'm curious with that, as you are seeing, you mentioned the FDNY algorithm, as you're seeing more patients come in, is there any way that you're sort of tracking the differential outcomes based on how long it's actually taking the patient from when they call 911 to when they're walking into the door, being journeyed into the door?
Yeah, so we're not necessarily tracking, ambulance response time. I know the city works on that, and our partners at FDNY works on that, and the various programs that's there to build to help with that. I think for us, when the patient gets to us, we make sure everything we can do, we're doing. I think this neighborhood is fairly close. It took me 13 minutes to drive here, but there can be an impact, but I think the city's doing as much as they can to help with that, right? I think it's various levels of trauma as well.
Yeah.
We're level 1 center, but
I mean, my overarching concern there is it's just going to be something that is lost in the data, right? That like you have someone who's experiencing symptoms of a stroke, and they call 911, they're picked up by an ambulance, and like it's time is of the essence. And it's a big difference if that is 5 minutes or 45 minutes.
Well, one thing I'll just bring in, we met recently with Northwell Greenwich Village Hospital, which has now added services for stroke. And one of the things that they, in addition to now having an additional place that patients can go, which is good, they told us that the new, maybe it's the same algorithm you're discussing at FDNY, they used to offer patients in an ambulance the opportunity to go to the hospital of their choice within reason, but now they don't do that anymore. Now they just take you to the place that the computer tells you is the closest that can serve the need. And so that might actually be in response to, I think that was in response to the times it took to get people to facilities and the times it took to get ambulances back on the street.
Oh, okay. Okay, that's interesting. Okay, a different question about the psych beds, because you said that you've absorbed more patients into those beds now that Beth Israel is closed. And you mentioned sometimes it is 0, kind of your capacity at those psych beds. What is your running open capacity right now? Because we hear a lot about how one of the issues with street homelessness is that we want to give people psychiatric care and there's nowhere, Eric Adams' proposal of like, grab them up from the subway and put them in hospitals. And I think some Bellevue leadership are like, we don't have money or room for all of those people. We will happily accept those. So I'm just curious, like,
where do we stand?
Where do we stand? What's sort of the capacity, the open capacity?
We're typically very constrained in terms of capacity. That varies from days of the week to different things, different consideration. But I think there are programs that we are working on that help, right? Thinking about respite care, is one. Bridge to Home is another program that's
Bridge
starting.
home.
Yes, so it's for individuals who might not have a place to go. They could stay. There's a new mayoral program that started. They could go to a location that essentially is a hotel slash facility that's within H+H that we're working to build out, and they will have on-site psychiatric care, right, as well. So it's
Where
they're
is
not. That will be based out of Bellevue, near Bellevue. So
Oh, it's not built yet. It doesn't exist yet.
it's coming in the coming months.
Okay.
You know, something for like psychiatric care, if you can't take them, then there is another hospital. So do you know overall capacity, let's say on the island of Manhattan?
I'm not sure about the exact
You
numbers.
don't actually,
Yeah.
don't know that, okay. And I may have missed it. Where are the other psych hospitals in the city?
I think almost all, I mean, Sinai takes many patients, right? It's there. Tisch has psychiatric care
It's
as well.
interesting that you don't know.
Columbia, New York State Psychiatric.
Are you?
So for us, it would be important, like, to understand and demand, it's just not just the one hospital, it's the constellation. Because there's somewhere, as long as there's somewhere for somebody to go,
Yeah.
it's okay.
So when we spoke to Northwell Greenwich Village and we talk about the closure of Mount Sinai, they're very quick to reassure us that it's going to be okay. And I sense the same optimism from you. And I think part of it is, I wonder if part of it is to protect your colleagues who just closed the hospital on us. Do you really think that it's fine? I mean, do you really think that the system has enough capacity to absorb all this? Do you think that this is going to be a struggle?
I think I can't speak to the motivations of closing a hospital.
No, I'm not
Is
asking.
that-
I
think
really just.
From
want
our
the impact,
perspective,
yeah.
I think we're here. Yeah, it's hard work. Everything is definitely hard work, but I think we're here to meet the challenge that's there, and we're confident in our ability to meet the challenge. Of course, there will be. There's always needs to improve the equipment, improve these things to make it easier on our staff, to make sure we're able to do the things that we need to do to meet the demand, right? I think that's medicine. We take care of people that come through the door, and we're going to continue to do that. I think we can't control what's outside of our realm, right?
Yeah, no, I understand that. I'm trying to understand the boundaries here. I mean, if Beth Israel closes, it's one thing. Okay, we can take it. What if Beth Israel and NYU
Northwell,
closed?
yeah.
What if Beth
I
Israel
don't think
and NYU
NYU
and Northwell closed? Like, at what point is it like, we can't do this?
I think it's difficult because I think we definitely need care, and as we need hospitals, we need outpatient care, we need clinics, right? There has to be a good balance out there. So I think hospitals closing in general is not a good thing for the community, and that's true, right? I mean, I think that care needs to be thoughtful and care needs to be segmented in the right way. So it's not always just about hospitals. It's also the other programs, right? Primary care, long-term behavioral care being available, right? Those things are just as important. Medicaid, again, going back to that, just as important, right? It's one thing to have the hospitals and overwhelm our EDs. It's another thing to have that long-term things in the community, right? So physicians, having a physician shortage, all those things matter. Like it's a comprehensive system, and I think that system, the continuum of care, is really important, and we always want to strengthen it. So I don't think the focus is just the hospitals,
Right.
but it's all of that. And I think we at Health and Hospitals try to work on all of those things. Like we've strengthened our primary care, we're strengthening our behavioral health, we're finding alternate programs. Treat Homeless program is another one of those things. Not all patients are coming to us, so we want to meet them where they are, right? Telehealth is another example of that. Post-care, right? Housing is a huge example of that, right? Whether it's respite care, it takes a little bit of time. I think one of the questions you asked Andy is, how do you get somebody permanent housing? That is a focus for us in the system. We actually built permanent housing, or are building permanent housing in Woodhall, in Brooklyn. We have other locations where we're building permanent housing for those patients.
H+H is building permanent housing?
With the city and others, yes. So that's like a part of it. Having respite care, so it's not housing, but as people wait for those time, they could have some care in a lower level we have those, right?
What is respite care?
So it's a patient that's discharged from the inpatient unit. Many times, they might not have housing or they can't be released to a shelter. So they'll be sent to one of our respite care locations where they are observed and there's more care available, some care available, as well as
Got it.
stay.
I'm curious because, it's sort of interesting. So we're talking about like going to NYU and I know I met people whose job is to keep the beds full because the hospital, like there's a balance, but they're actually kind of happy when they have their beds full because they're bringing in income. It's bizarre. Do you know there are people, that's what their job is. I met this one, her job was to keep the hospital full. That was very interesting. But so if you're partners with NYU, so there are times when Bellevue is at or close to capacity. Do you know how NYU is doing for capacity?
We're partners in the sense like our physicians are working in place. I don't know their.
Because you're so close to each other. Like if you were both at capacity, that's a different picture than if one of you is.
I think that varies and there's slightly different patient population, or maybe it's a different
Right.
patient population. So I think that makes a difference. I think different models in terms of like insurance and other things. I think for us, because we take all patients, it creates a distinct challenge for us. So we are full. I think hospitals tend to, we want to run efficiently, right? We don't necessarily want to have empty beds because they're staffing those beds, right? So we want to be able to meet the needs at the time that come in, right?
And have you seen a plateau in your, is your demand consistently going up or is it sort of plateaued?
So most recently it has plateaued. So that's we're stable at this point.
Recently in the last 2 months or?
Yeah, in the last 2 months, it has plateaued, right? And so we are trying to see what the impact will be in the winter months and other months, but we are working towards that, right? And we're making sure that we're ready for any patient that comes in through the door.
And do you have room to grow, to expand your facility to create more beds?
Again, that comes with, it's an old building. The building was designed in 1958 and opened in 1973. And some of the infrastructure is original to the building, including, the technology, the equipment and other things. So it requires funding in order for us to open new beds, right? It's not something that we can turn on.
So the closure of MSBI, has MSBI conceded to contribute anything toward H+H? We've heard rumors that they're gonna give one CT machine.
Yes,
Like,
so.
what is the deal? And is that something that the state is imposing on MSBI? Like how?
I'll just speak to the.
Yes, what you know.
To agreement, they are helping us with the CT machine. They are helping with some financial means to improve our ED, right? So we're leveraging some of the funds from the agreement to add those things. So we'll have 2 CT machines on the first floor for the ED. We'll have the new fast track ambulance bay and other projects that's there to optimize the locations that we have.
So
the respite bays.
how much money would you say is?
So it's about $20+ million, I think that we're able to have agreement on.
That seems like a drop in the bucket. I mean, honestly, it just seems like that's not, okay. The other thing patients experience that is the feeling of whether a facility is over capacity is the time it takes to go from the ED to a bed, when you're waiting for a bed. And my stepmother was in NYU ED for 3 days before she got a bed. Do you guys look at that metric and where do you stand with that metric? I guess as an absolute number, it would be hard for me to understand what that is. But over time, like what is going on with that number?
It has significantly improved. Again, the lean team concept that we talked about that I co-chair, we've been able to really decrease the borders in the ED and make sure individuals are coming upstairs, right, into a bed. And we have seen significant improvements there as well. So again, improving our operations, thinking it through, and working through that, right? So we have done a fairly good job, I would say, knock on wood, and we'll continue to build efficiency. We used to have at times 60+ boarders in the ED.
Borders?
Boarders meaning individuals that are waiting for
That's what
hours or days,
I see.
because they're admitted, they need to go upstairs.
Right.
We don't have a bed, so we're keeping them in the ED. That's down to some days, it's down to 0 for now, right? So that's more efficiency. And then, other times it might be 10, 15, it depends on the time of day, what it is, what's happening. But we've done a fairly good job so far of managing that need and keeping that there. I think ultimately, I think of myself as that patient that experienced health in a hospital. So we want to keep that in front and center and make sure we're doing everything we can to have the person be in the optimal setting and ideally go home when they need to.
What is the budget of Bellevue?
We typically have about a $1.6 billion budget.
The idea that
That's
we're gonna
annual,
get
right?
$20
Yeah.
million from the closing of a hospital, when you have a $1.6 billion budget, it just seems like that, whatever. It boggles my mind. Sorry, Jenna, you had another.
I just had a question, and you mentioned it, and I think it's very interesting because hospitals like to get you out of the hospital really fast now. Like they're like send you home, carry your catheter with you, whatever. So you said that you're developing this sort of intermediary step, sort of a place for people to go where they can't go home. Can you talk a little bit more about that?
So those were the 2 programs I talked about. It was the Bridge to Home for psychiatric patients that could be safely discharged to this program. And they could spend some time there recovering, right, fully recovering. So it's not, if they're not higher acuity or they're not meeting the needs, they need the hospital, they could or not. The respite care was the other location. Again, the patient is safe to be discharged, but they don't have a place to go, and they might have some small needs. We have locations for that as well.
So in
Those
both
are
of these
great
cases, this
programs.
is for patients who are homeless.
These are, the respite is typically homeless patients. For Bridge to Home, it doesn't have to be.
Got it.
Like, we always wonder if there could be an intermediate step because people are not quite ready to
Go back to life.
go back to life, and they need a little bit more time, but they might not need to stay in an inpatient unit.
Right.
So Bridge to Home is that gap.
So that probably helps you kind of clear out the beds to get.
Helps, yeah.
That's a very critical piece.
And
It's
I'm
like a
gonna get-
nursing home, but for people who aren't.
Well, like a
elderly.
rehab facility,
Right.
like if you
Yeah.
have orthopedic surgery, you go to a rehab facility, or whatever, not just orthopedic.
Yes.
You go to a rehab facility, so it's sort of like a lower level of care that is higher than being at home.
Yes.
And what's the size of both of those programs?
Respite, I think we're up to 125 beds now. This is citywide, but Bellevue does utilize
325?
125, yeah. And for Bridge to Home, I think we're growing to 50. That's the intention.
And do you discharge people to the street or to shelter?
We do,
I mean, I know at Columbia, that came out, sometimes it was people who refused to go to shelter and they wouldn't leave the hospital and they were well. It's a very tricky situation.
yeah, I think that is a issue we run into from time to time where we're not able to safely discharge, and they do stay in the hospital and for a long time.
Oh,
I
really?
think we have some
Years.
patients that have been there 7 years.
Years.
Yeah.
I guess it's a clean bed.
And sometimes the patients want to be discharged.
Wow.
So
But anyway,
It's a
rare.
requirement that we have a safe discharge, right? We can't just send people out the door without that. So these are ALOC patients on the level of care where they don't technically need to be in a hospital, but they don't have the follow-up or locations to go to. They end up
Wow.
staying in the hospital. That's a significant,
Bummer.
Drain on
What it
the
is.
drain.
Drain on
Significant
resources. So those
bummer.
are the people you're trying to get like into these.
I think there's different levels to it. Yeah,
Yeah.
there's various levels to it, but yeah, we're
That's
trying to. So having a home is important in that regard, right? So that's where building housing is almost better sometimes for some patients.
Preach, my friend. You mentioned the diversion rates a while ago. Have you seen changes in your diversion rates
I think,
with the closure?
yeah, in the ED, no, I think we're fairly stable and we've been able to do well. I think in the CPAP, we have seen a little bit more diversion. I could get you the exact numbers. I don't have a top.
But it
head,
hasn't
anecdotal.
been drastic.
Not drastic.
Okay.
But getting a diversion and see, I mean, you shouldn't have to divert at any time. Whatever. I don't know, actually. I'm
I
totally out of my
would,
depth.
it's funny,
Where
you
they
say,
go.
you say that, I would honestly be more worried for the ED diversions, because that like, if you're diverted to a hospital that's quite far,
Yeah.
that I think is much more difficult, because
Yeah.
depending on where your family is, or you are, and the community is in the hospital, and you're low income, and your time's a premium, like that can create, I feel like, a lot of difficulties. The CPAP, I think it's
Although Northwell said
Different
to
there.
us that you request a diversion, but you don't always get it. And then she said, you know, of course, if you're diverting, chances are all the other hospitals are diverting because there's something going on in the city, whatever, I don't know. It's a feel like,
So are you guys prepared for the big, beautiful bill? Do you have like, look at what you're gonna do?
I think it's a work in progress, and I think this is where we look to our community, we look to our patient population, we look to everyone to just talk about what the impact will be, our electeds, and really try to change hearts and minds and bring some sanity to the world. I know I did a Medicaid video, right, talking about like my experiences getting served by H+H and why that's important, and advocating for this bill not to cut Medicaid funds. We have several articles by our CEO, Dr. Katz, from the system perspective, speaking of the same thing. So I think we're hopeful maybe some sanity will come to the world, and if not, I think H+H will always be there. Will be there. It's a matter of how do we do the most good with the dollars that we do have and serve the population the best way we can. So there'll be tough decisions in the services we do provide, right? And thinking about that. So that'll be in the coming months and years to navigate.
I think we're a distant advocate for the federal government. But we do interact much more, of course, with our city and state representatives. And so I'm curious.
I was gonna ask the same thing. What should we be
You,
advocating?
you asked.
No,
go
I'm so
ahead.
sorry.
No, sorry.
No, go ahead.
Yeah. I didn't mean. Sorry, I didn't mean you asked.
No,
it that way.
you should be asking. I'll just shut up.
Anyway, what should we be advocating for from our electeds that are more within our sphere?
Yeah, I think for us, the priority for this year was those equipment, CTs and other things. Those
Okay.
are roughly about $5.3 million for the 3 items that we put on the list. And then we think about like, okay, how do we continue to serve? So the PICU was another priority for us. That's about $18 million that we're looking to get. And I think anything in between, there's a whole laundry list of items, but if I had to pick, those would be it, right? The CTs and the single plane and the PICU.
I didn't hear on that list, city land to build additional hospital space. Is there a reason?
Hospitals are.
Just to really drive that home.
I think there's many places that are landlocked, right? So there's not enough space. I don't know if land is necessarily always the challenge. So I think few things from that perspective. We do have units that could be renovated or built, right? If we were to go that route. We do have a small project that's coming. So there's a science park, life sciences building that's being built on First Avenue and 26th Street. It's a huge project with EDC, and we are slated to get 6 floors of that building. That will become a community pharmacy, a radiology. It'll become a SIM center, as well as ambulatory care, so ambulatory surgery center, and additional space for primary care and pediatrics, which will allow us for our current basically current space that we're using for ambulatory to become specialty ambulatory, right? Which will immensely helpful. It's slated for 2031, so it's a little bit far away, but I think that's a growth, and that we're definitely looking forward to that. And OMB and the city has been helping fund that OBEC. So I think we're looking forward to that. And then of course we have those lists of areas that we want to improve, right? We want to, so the PICU is one, we have 7 beds. We'd like to get 10 beds and have an actual modern unit that's conducive a NICU, we want to expand the number of beds in the neonatal ICU.
The
We're
neonatal
full. We're full, like, we have 25 beds, we're full all the time. We'd like to expand that by like, five beds or so, or 7 beds right there. So I think there's dollar amounts tied to this, but those are things that we could work with.
I mean, I can't help my rage toward the State Department of Health over the closure of Beth Israel. And so I keep wanting to advocate to DOH to try to extract more money from MSBI for these things, because I feel that DOH has given MSBI a real easy time with it. Is that something that is just, I don't know. There are no ongoing negotiations, I presume, between you guys and MSBI.
No, I mean, I think, I think every citizen advocates for what they see fit
Say that again.
best. Everyone advocates for what
Yeah.
they see fit. I think from our point of view, I think we're only really concentrating on us and what we need to do and what's the best way to get there.
Right.
We want to work with everyone and just make sure that, we're able to serve our patients. That's always the goal, and we're working with that. I think we would love for you to visit, all of you to visit, right? Happy to take you on a tour of Bellevue to see it, right?
Happen to have seen a lot of Bellevue recently because my dad's caregiver had an accident in their house, and I went with her to the ambulance, and she went to Bellevue emergency room, and then she was admitted. She got excellent care, I will say. She really did get excellent care. And I have no idea how she paid for it. But anyway, that's about as much as Bellevue as I need to see. This is really
Thank you.
helpful, and
Yeah.
we're really grateful for you sharing all of this with us. I think I'd like to have a conversation with us as a committee to see if there's anything we want to advocate for, whether it's screaming into the wind or not.
Well, I mean, it's helpful because you've been very specific about your wish list, your top, 4 or 5 things. It's very
Yeah.
good for us to hear.
It's good for us to hear because, for what it's worth, we are invited to submit capital requests to the city, most of which are like, yeah, that's so nice, thank you so much. But at least we can ask and show that the community supports that. So, thank you very much.
Thank you for
Yeah,
coming.
thank
in.
you.
for having me.
Yeah,
I'll
that's amazing.
look, I haven't even looked at the attendees to see if there's anyone, if Donna or Nicole wanted to ask a question or make a comment, this is the time, because we're gonna say goodbye. Okay, I don't see anybody, so great. Thank you so much.
No, thanks for
Thank
having me.
you.
This was really
Yeah,
interesting.
really
Yeah,
nice.
Yeah, I really appreciate it.
Really appreciate
Leave my
Yes.
time.
I'll take your
Yeah,
card. I'll take your card.
Yes, and thanks for joining us on that
yeah, thank you.
Yes.
Thursday night.
That's when NYU comes alive.
So you're gonna go to dinner in the neighborhood now?
I'm gonna pick up dinner and go home. I
There you
have 2
go.
kids.
There you go.
How far is?
How old are they?
I'm in Long Island now, so Plainview,
Yeah.
Long Island.
Okay.
It's a little bit far, but this
They say
time
the traffic should be chill.
Yes.
it changes. It varies. It depends. But and I have to pick where I want to go. Right. I want to go to Molly's. There's Tucky Roll.
I love it, bro.
It's a good place.
All right, well, thanks again.
Thank
Thanks
you.
a lot. And if you
Very
guys don't mind,
much.
we're gonna go into business session. I just want to get a feel for all of this. We don't have a quorum,
No,
but that doesn't mean that we can't do.
are we one shy of a quorum?
Have a good.
We are one shy of
Need
a quorum. Well, we're a committee of 9, and so we need 5 people.
But we are
And
5 people.
unfortunately, Rachel doesn't count.
Public members don't count towards
No.
quorum?
That's like a
recent learning.
Oh, that's rude.
I never knew that.
I know.
I've been on this thing for a long time. I guess my question to all of you is, do you think it would be helpful or interesting to write a resolution of any kind?
I mean, I guess I don't see. I don't know. I'll let others talk first.
No, go ahead, Jim.
So I guess talking about writing a resolution, I mean, the gentleman was very clear about their primary needs right now. So do we say that we heard them and we understand that they're managing and needs a plateau, but that these 4 or 5 things would be really helpful and we would resolve that the city should
I don't know. I mean, I guess my thinking is that we will make requests in the fall. And it's helpful to have a resolution before we make those requests so that we can say that these requests come out of a community interest, right? It's not just four of us in a room. We've written a resolution. Our board has voted in favor of it, and our board agrees that we would like to ask for these things.
And the dollar amounts weren't crazy, right? Even one was like
No,
5
they
million, I
weren't
mean, you know,
crazy.
3 for the machine, 11 for the PICU.
18.
Oh, excuse me, 18 for the PICU.
18 million.
Yeah.
No, they're all, I mean, I do think that
I mean-
the infrastructure is huge. I mean, just to redo that into a modern hospital that's billions. No, because we had some of that at Columbia, because we had ancient property and trying to, you need new buildings. It just, it's
Yeah.
very hard to make an old building into a new hospital.
Yeah.
Well,
In
it's like-
resolutions, do we often include such specific
We don't
funding
have, I don't think that
amounts?
we have to be specific.
Mm,
I think that, I mean, in terms of, I mean, my thinking is we want to be able to express that even though Bellevue is not our local hospital.
Right.
We feel that we have an interest in its thriving.
Yeah.
And that the closure of Beth Israel makes that even more important.
And
And-
it did have an impact.
mhm.
And it has had an impact on its
We're
capacity.
hoping, but you could,
And, you know, there are some things that Bellevue has expressed would help it to improve its services, and those are, they mentioned, you know, CAT scanners and plane machine, whatever that is, and.
I've never heard that, but yeah.
Right, and we don't even have to be specific,
Yeah.
just say, you know, that we know that they've made requests, and we support those requests.
Yeah.
I mean, because he was so specific with us, it seems like it would be okay to be specific about those particular
Things.
Sure.
machines.
Yeah.
Stroke one is a new thing. That thing is a big deal.
Really?
Yes, because people with strokes now used to have, obviously, they would
Yeah.
be impacted for life. And if you get into one of those machines and they fix
Suddenly.
it, you walk out, you're done.
Oh,
That's so
gosh.
crazy.
You're fine.
And I think
It's
that
amazing.
Northwell has that now. I mean, I don't
That's
know
very
anything
notable.
about stroke here, but.
But
I do think the other thing that, there are no capacity on the psych beds.
There was.
No capacity. I know he did not say that that was something that he was like asking for more money on, but if we do write a resolution, like this is like a perpetual issue. And I think with the closure of Beth Israel, it's like they're full
Yeah,
with their psych beds, and like there are only so many beds in the whole city. And so maybe we can include something that kind of speaks to like
I support that.
continued ability to enhance the psych services.
Yeah, because also this community, one way in which we really do directly rely on Bellevue and did on Beth Israel is we have a high level of people, it appears that we have a high level of people with mental illness and drug addiction. And so that's our facility.
And especially since we, you know, the people at show, we're like, oh, if someone's in duress, we put them in an ambulance.
exactly, yeah.
So we put them in an ambulance and they end up in Bellevue. Like without a doubt, that's where they're gonna end up. There's no way they're taking them to Northwell.
Well,
they're
the
not
site, they
taking
can't
psych
take
anyway, they
No,
don't.
they don't take psych.
No, they don't take.
But I doubt they even take them to NYU, honestly, like.
Oh, NYU doesn't have a CPAP.
So who
I mean-
has that? So
Only
Bellevue and who
Bellevue.
else? Bellevue is the only place.
Well, it was
that's
Beth
allowed?
Israel and Bellevue, but
So
now it's
that's
only
Down, he said the only one below 50.
Below, but Columbia has it.
50.
Yeah, but yeah, it was a funny street. I was
What
like,
are the-
what
I
a
know, I thought
random, what a
that
random
too.
line.
I want to see it on a map.
Yeah, he said it was the only, I think it's the only one all the way downtown. So it's like, that's where they're going. They're going to Bellevue. So I
That's
think
where they're
it
going.
makes sense to at least say that
Yeah, I'm
It's the
considering,
catchment.
And then we,
considering that all the emphasis that the mayor and the governor has placed on the need to address serious mental illness. It's a big
I mean,
deal.
the governor, they put extra billion, they've had so much money going into mental health, they can't spend it properly. I mean, they don't know what they're doing.
It's like a build a new floor for Bellevue.
And do we want to mention this Bridge to Home, just to highlight a couple of programs that we thought were valuable?
Sure.
programs?
Yeah.
So bizarre, I do feel, and I've thought about this for 20 or 30 years, it's very odd that hospitals, using hospitals as default positions for our other societal needs. They should not be in the hospitals.
Yeah.
Agreed.
Right.
I mean,
I think that's a great idea. I like the idea of those programs. I think to me, it might be a little early for us to be like, yes, this is good, because I think it sounded like they're still launching and conceptualizing, but I think in general, like, you know.
We can make a broad comment that the
Yeah,
hospital.
totally.
They're not,
Hospital.
Innovative thinking and.
Yes.
Yeah, we can appreciate, we're encouraged by it. We're
Yeah, totally.
for it.
Yeah.
Don't have to commit
Yeah.
to it.
But I mean, if it's launching in a couple months, it would be really great actually to have them back maybe like near the end of the year,
Yeah, or-
early next year.
Once they have like.
Just to get a sense of like,
background.
how have these been and how are they working?
Yeah.
How are you getting people out of them? But that's a future.
So did you say they weren't up yet, that they were just they were new programs
I
that they
wasn't
were
really-
starting?
The
Yeah.
Bridge to Home,
Bridges.
he said, is launching in a few months.
Okay.
I don't
The
think I
respite
asked about
care.
the respite care, whether
My
that
impression
exists.
that it's live.
I think it's live.
I think
Is
respite,
it out near Wood?
I don't know.
That,
I don't know who buys the respite care. I got the impression that it wasn't a Bellevue facility, that there are other facilities that I have no idea.
It's wild that there are people who've been in the hospital for 5
I
years. I never heard that. Oh my God.
Food is like.
Oh my God.
That is just so long.
It like brings.
But the other
It really does.
the risk-
Never left the hospital in 5 years. That is
The
insane.
alternative, then again, I'm on the ethics committee of the Columbia, so we get these cases of
Yeah.
people who want to be discharged to the street or in their whatever.
Oh,
They will not go to a shelter. They will not, if they find them supportive, they won't go to it. And so you have a choice. You try to keep them in the hospital or they'll walk out on their own. But there are unsafe discharges going on. People,
And why do we?
But
Sorry,
you're
can you
not
just expand
compelled
that
to.
a little bit? I like don't understand the,
But if they don't have a home, they're
They
not
don't have a
compelled to
home.
keep them.
yeah,
you're supposed to not discharge anyone to unsafe discharge. He said he had a
Yeah.
mandate not to do an unsafe discharge.
oh,
If they have nowhere to go, then you have to keep them in the
so
hospital.
you ask.
But I would say that sometimes.
If they want to stay.
Sometimes the patients themselves will.
We'll just leave. Okay.
They'll unsafely discharge
So
themselves,
they're technically not discharged, but they will.
or they're leaving against medical advice.
Got
yeah,
it.
that's why this other, this is
So
important.
there are these different things, but
That is interesting.
The good news is I went to a presentation at NYU for, I think, connected to one of these services. And the woman said that the number of chronic cases is actually fixed. It's always roughly the same.
Chronic
number.
disease.
The people with chronic mental illness, who
Oh,
need
chronic
care on the
mental
street, that's why they have these vans going out to help them.
Got
She
it.
said it really boils down that there's, I don't know, it's 10,000 or 15,000 or 6,000, but there are a fixed number.
this
Oh.
doesn't keep climbing.
It doesn't keep
Doesn't go
climbing,
down.
and it doesn't go down, but it
Right.
doesn't keep climbing. Like they know that.
Yeah, they know them. Yeah. Yeah.
So it's really interesting.
All right, guys, I will take a stab at this.
Yeah.
With the help of ChatGPT, which I have not mastered.
So do you take the transcript and feed it into ChatGPT?
I'm so bad at this. I've taken the transcript, I've taken the recording and fed it through Otter, which makes a transcript that is better than the Zoom transcript. And then I've taken the transcript and I fed it to ChatGPT. This is like, I'm making so much more work than it's supposed to be. And then I have to read the ChatGPT summary, and then I add.
Quicker?
It is quicker, actually. And some of the stuff that ChatGPT is like, oh my God, thank you so much. That just saved me so much time. But obviously I have to go over it, and then I tend to we ask for a summary, it doesn't add everything that you
Yeah,
want.
there's an article in the paper.
I haven't
about
trained it. I don't know how to
much
train it.
energy each of these things takes, like
Oh, yeah.
how much we're consuming in the world.
Oh, yeah.
I just learned that we're not supposed to say thank you to ChatGPT because it just burns energy and doesn't care.
Really?
There was
And
a-
I felt really
there
sad
was a
about
very-
that.
there was a very-
I was like, what are we teaching society to
There-
like do?
There was actually an interesting interview with Sam Altman who
Oh,
talked
really?
basically about that. It was like, yes, it costs opening a.
I'm just gonna adjourn the meeting.
Oh, sorry.
Bye, everybody.
Bye, everybody.
Don't think your AI.